welcome to BPD Awareness Day 2025. My name is Bailey, and I'm the co-founder and president of the BPD Society of British Columbia. I'm a person with lived experience of BPD. I'm also a registered social worker, and I'm also a DBT therapist in private practice. I help develop and implement our peer support groups and DBT programs across British Columbia with the support of our team and board. Today is our 7th annual BPD Awareness Day, and it's dedicated to spreading awareness, ending stigma, and furthering research. It also helps to celebrate strengths and raise funds to support folks in receiving access to proper treatment. Thank you for joining us today to learn more about BPD and validation and ways of coping, debunking myths, and increasing hope. You will hear inspiring stories from people living with BPD and family members and from professionals working in the field. This event will be recorded and uploaded to our YouTube channel afterwards if you'd like to subscribe. Deb will be one of our co-hosts today, and so will Brian. So they'll be dropping some links throughout the day. If you have any questions for technical difficulties or need support, you're welcome to message them. And also, if you have any questions for any of our speakers throughout the day, just send them to me, and then I can ask the speakers. So we are a registered Canadian charity, and if you would like to donate at any time towards our fundraising efforts to sustain our new DBTA for adolescents or to add other additional DBT groups, such as a standard DBT for rural and remote communities, we will be dropping a link in the chat throughout the day. So our event will go from 12 till 6 with a guest speaker on every hour, followed by a community connect in between presenters. And that will be a time and space to be able to ask questions. We'll have a prompt and then we can have a discussion. It's kind of like a mini support group. And today our speakers, our keynote speakers this year will be Dr. Connor Hawkins, Lori Edmondson, Mia Pohl, Lauren Reese, Dr. Kiki Felling, and Josh Escobar. Okay, so I will start with our first presenter today, and that is Dr. Connor Hawkins. And just one moment, I'm going to here. Okay, welcome, Dr. Connor Hawkins. So he is the psychiatrist and medical co-lead of Personality Disorder BC. He completed training in transference-focused psychotherapy through Columbia University and TFP New York. Dr. Hawkins is a clinical instructor in the Faculty of Medicine at UBC, where he is involved in the psychiatric residency training program. He has published on the topic of personality disorders in the Harvard Review of Psychiatry. His topic today is Bridging the Research-Practice Divide, the Evolving Landscape of Personality Disorder Treatment and its Impact on Patient Care. So thank you for being here with us today, and I'll hand it over to you.
Thank you very much for having me. Yeah, very excited to be here. Yeah, so there we go. Also want to start land acknowledgement. I humbly acknowledge that I live, work, and play as an uninvited guest on the traditional, ancestral, and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh Nations. This is UBC, where I work and am coming from today. Important to be upfront about conflicts of interest. So we run a MSP, a publicly funded psychiatry practice offering transference-focused psychotherapy, TFP. I think there can be, a lot of factionalism between the different three-letter therapies. I think just, having a healthy pride in one's work is important. But I want to acknowledge that, because I think if you come away from this presentation thinking that TFP is the only therapy option, then I have grossly misled you. I think to try and mitigate this bias, I in the different therapies that I'll talk about, I've taken the text like directly from the guidelines to give each one a fair shake. And I don't have any other funding from pharma or anything else. So really objectives today, I want to update people on advancements and how we conceptualize personality disorder from a research and academic perspective, and review current treatment options for personality disorder that are considered evidence-based in the literature. I think this is really important because I think it's really important that people know that these evidence-based options are out there, and essentially advocate that we'd be able to offer them in British Columbia. I think it's really important to start big picture. I think we're in a very exciting time in terms of both explosion of new treatment options that have become mainstream over the past decade in particular, as well as active research that has really significantly changing, I think, our underlying understanding of personality disorder more fundamentally. And I think a really important kind of consequence of this is, from a clinical perspective, no longer should we be trying to make one single treatment option work for everybody. I think we should be asking each other and ourselves, like, what is the right option for a particular person at this specific point in their life? Because something may not be the right fit for somebody right now, but that doesn't mean that it never will be. And then also, having a robust, informed consent discussion about these are the options. What would you like to do? In terms of our changing understanding of BPD, I think some historical context is helpful. This cluster ABC system, DSM, was introduced a long time ago and is still used clinically for the most part. It leads to a lot of questions about, like, well, what even is a personality disorder, which we'll talk about in a sec. But the system, this cluster ABC system, certainly has a lot of valid criticisms, but I think we were just talking about two things being true at the same time. It's also been really, I think, instrumental in providing a scaffold for decades now of research on personality disorder that has now brought us to this new model, which I'll talk about in a sec, the AMPD. Um, and as a result of this research, I think we're now in a very time of significant transition in terms of how we think about personality disorder. I think thinking about the way that we've talked about, like, 5 of 9 criteria, and it reads kind of like a laundry list, and how do these things even go together? And people can have, it's like, nearly infinite different combinations of the 5 of 9, and are those really the same thing? Or are they different? Or is it a spectrum? So that then brings us to what we call the alternative model of personality disorders, which is, I think, really where the, like, research community is at in terms of you know conceptualizing personality disorder, and ideally diagnosing it as well. But I think, as in my title, I think there's a really big gap between what we're learning in the research and then what's happening on the ground. I think a big part of that is um, that things are moving and changing quickly, and it takes time to catch up. But I think it's also very exciting that things are moving and changing quickly. Um, so the AMPD, first of all, the AMPD, instead of this sort of like, yeah, this like a theoretical laundry list, 5 of 9 criteria thing in the cluster ABC system, has really more of a focus on a spectrum of difficulties. It's not like a yes, no, how many of these criteria do you have? It's more looking at all of these traits like existing on a continuum that everybody's on. And when we start thinking about it being a difficulty for somebody is when it's when these traits are getting to the stage where it's causing somebody distress or difficulty functioning in their life. And so along the spectrum, it's we emphasize criterion A being this degree of difficulty in what we call self and interpersonal functioning, which I'll talk about in a sec. And that spectrum of this difficulty, I think it's important to emphasize that it's criterion A, I think, kind of implies that this is the first thing. It's very important. And then the kind of second criterion B, then has a number of personality trait specifiers, like separation insecurity, impulsivity, perfectionism, emotional lability, et cetera. But the real focus is on self and interpersonal functioning, and yeah, existing on a spectrum. So what are we talking about when we say self and interpersonal functioning? So under self functioning, one of the first things we're talking about difficulties around identity diffusion, having a relatively consistent sense of self across time, and it being, it really uh, makes it very difficult to navigate the world if one sense of self is changing on a relatively short time span, and then that gets into the second criteria around self-direction, that if somebody's sense of themselves is changing um, relatively quickly, then it becomes difficult to engage in a sustained pursuit of something that is of important to the individual person. And again, it's important to emphasize these things exist on a spectrum. Having a different sense of self around your boss and around your romantic partner and around your friends is probably actually a good thing, and a sense of self that's so rigid that it becomes difficult to have that kind of flexibility with a boss or a romantic partner or a friend, then becomes kind of its own thing to think about around identity. Um, and it's also normal, across the spectrum, across the lifespan, people's sense of self changes over time. But I think it's more when there's people have no idea of who they are, or their sense of self is changing so significantly that it starts creating difficulties in their life, that we start to look at this as something to target in therapy. Um, and then the next section around interpersonal functioning, we're thinking about difficulties around intimacy and empathy, or what I prefer to call mentalizing. But with with intimacy, what we're talking about is being able to both tolerate being close to people, but also tolerate being separate from people. And a lot of people have more difficulty with one or the other. And um, that then ties in to in the textbook empathy, what I prefer to call mentalizing, but basically somebody's ability to naturally intuit like what this other person you're interacting with may be thinking. And I think the intimacy and mentalizing piece really go together, that if somebody is, because of a trauma that they've had in their life, kind of primed to view other people they're interacting with as having malicious intent, then that makes it very difficult to be close to somebody. So yeah, these two things tie together. I think in terms of a research perspective, a mentalizing perspective, this is where there's a lot of discussion around like BPD and autism, in the sense that the way the personality disorder academic community looks at mentalizing, being able to understand what's going on in your own mind, as well as what's going on in the mind of the other person, has some overlapping features of the way that in autism research they talk about theory of mind, or being able to understand what's going on in the mind of the person that you're interacting with. But, and of course, it's possible to have both at the same time. But there's also, I think, a tremendous amount of misinformation online, on TikTok about this. But I think that that's sort of a point of intersection between those two. So, in terms of a research and a treatment perspective, there are brand new guidelines that came out in November, that really highlight all of the different treatment options that, unfortunately, I think a lot of people aren't aware of. And it's important, I think, that people are aware of them and are asking about them, to help, stimulate these then becoming available where people live. It is more challenging than, I think, like a new medication, that it's you can just make more of it in a factory somewhere and then ship it over. Becoming proficient in a new model of therapy takes more time than just making more of a medication. But I still think it's important that we're advocating for more options for people, so we can, like I was saying, really match people to what the best option would be for that specific person, instead of trying to make one option work, even if it's not the right fit. Um, DBT is probably the most well-known of all the different three-letter therapies for BPD. Is it the only or all-around best treatment for BPD? In the research, the answer is no. There's a big review in 2017 that looked at kind of all the different therapy options for BPD that they could, get data for at that time, and no one specific model or no one specific three-letter therapy was globally superior in all situations. From more recent work, we know that it's likely the case that some people are better matched to one kind of treatment versus another, which, when you think about it, is kind of intuitive. And so, in summary, there's no one globally best treatment for BPD. The most recent guidelines list 7 different options, which I'll talk about briefly. And the field is really moving away from trying to find the one globally best therapy to matching the right person to the right treatment at the right time in their life. Um, Over the past couple of decades, there's been lots of head-to-head studies comparing like DBT versus GPM or schema-focused therapy versus TFP, all these kind of horse racing studies. And I think we're kind of moving past that to not which one is globally the best, to who should be matched to which option and when. So what are these different treatment options? So this is a table straight from those guidelines that I was just showing, and they list, these are the 7 different ones, and these guidelines are freely available online, and so you can find this online for your own reference if you want to look. But this table breaks down like what the different kind of components of the therapy look like: individual, group, family involvement, what it looks like, in emergencies, how manualized is it, is there evidence for adolescence, all this kind of stuff, trying to summarize the different options in one table. So we'll go through these briefly, one at a time, in the specific order that they're listed here. And again, with the phrasing from the guidelines to try and mitigate any bias. DBT. DBT is a multi-component approach that has efficacy in treating adolescents and adults with BPD, but may also be useful in treating people with other diagnoses who are at significant risk for suicide. A key focus of DBT is to help people develop a proactive problem-solving approach and to learn to tolerate stress, regulate emotions, improve interpersonal effectiveness, and develop mindfulness as a way to address emotional dysregulation. At the core of the therapy is a philosophical dialectic between self-acceptance and strategies aimed at change. Skills worksheets and a specific protocol for addressing suicidal thoughts and behaviors are incorporated into the therapy. It typically includes 6 to 12 months of treatment with 1 hour of individual therapy and 90 minutes of group skills training weekly. Treatment team members are also available by cell phone for skills coaching between sessions in the full model adherent version. Although DBT skills as a standalone intervention has more recently shown comparable effects to the full multi-component approach to DBT, when individual therapy was replaced with a case management style intervention. This is a less intensive intervention, and DBT skills training may be more accessible than multi-component DBT. I think in my experience, a big drive to kind of strip out specific components of a therapy are largely driven by the by like economic pressures, basically trying to do things as cost effectively as possible. But I think it's also important to note that we have good research now showing that DBT more than pays for itself. So it may be an expensive intervention, but there are also lots of expensive interventions we do in healthcare all the time. Some antibiotics are extremely expensive, surgeries are extremely expensive. Yes, it's a big investment, but it more than pays off, both for the person as well as just at the most brutally utilitarian financial bottom line. So it's important that people are advocating for more public funding for this. The next is dynamic deconstructive psychotherapy, or DDP. That's the next three-layer therapy. DDP is a manualized individual psychotherapy derived from psychodynamic psychotherapy that uses the philosophical concept of deconstruction as a framework for treatment. Links to neurobiology are also part of the theoretical foundation of DDP, excuse me. Therapeutic interventions focus on approaches such as alliance building, reflective listening, describing emotion-laden experiences as simple narratives, recognizing and addressing polarized attributions, learning to assess oneself from an external perspective, and facilitating mourning of the limitations of oneself and others. Um, Recent interpersonal experiences serve as primary examples for discussion in the therapy, although DDP also includes dream exploration, artwork, and creative writing. It's typically 12 to 18 months, delivered weekly in 45 to 50-minute sessions. Other interventions such as interpersonally focused group therapy, art therapy, or 12-step programs can supplement DDP. Next is MBT, mentalization-based treatment. As the name implies, MBT focuses on mentalization. That's, again, one of the parts of the AMPD that we were just talking about. The ability to reflect on one's thoughts and feelings as well as those of others. Without such an ability, it's challenging to have a realistic emotional perspective on interpersonal events, particularly under stress. In MBT, the therapist guides the person in learning to assess the emotional aspects of stressful interpersonal situations, such as those related to attachment, and then adopt a more realistic behavioral response. The therapeutic relationship can also provide examples for working through these steps, although transference interpretations are not used. We'll talk about transference in a sec when we talk about TFP. MBT typically includes 12 to 18 months of treatment with 50 minutes of weekly individual therapy and 75 to 90 minutes of group. In adolescent therapy, family therapy is incorporated to the treatment instead of group. Next three-layer therapy is schema-focused therapy. Schema-focused therapy is based on the concept that individuals view themselves and others in terms of cognitive schemas that are an outgrowth of developmental experiences that manifest themselves in persistent patterns of thinking, feeling, and behaving, although they are often outside of conscious awareness. Kind of the working model for how relationships between people and relationships with oneself should work. In BPD, these kind of working models that usually were adaptive at the time that they were formed and corresponded to a situation that was going on for the person at the time, then persist beyond a period that is then no longer adaptive for that person and can get that person into trouble. If they become strongly held and end up controlling a person's life through recurring and rapidly shifting constellation of intense emotions, thoughts, feelings, and behaviors. These dysfunctional schema modes are addressed by fostering attachment between the person and therapist, as well as by applying behavioral, cognitive, and experiential techniques, including homework. Schema-focused therapy also incorporates emotional awareness training and education for patients, and uses individualized plans for managing crises. In clinical trials, schema-focused therapy has been delivered in individual 50-minute twice weekly sessions for 3 years or in weekly 90-minute group sessions for 8 months. Next is STEPS, systems training for emotional predictability and problem solving. STEPS is designed as a supplement to other treatment approaches and is delivered in a seminar format using detailed lesson plans, weekly 2-hour groups for 20 weeks, as well as a single 2-hour session for families. It incorporates education for patients and skills training in emotional and behavioral management, viewed from the context of social and family systems. Participants are asked to monitor their thoughts, feelings, and behaviors over the course of the program to increase their awareness and identity improvements. Transference-focused psychotherapy. TFP is a manualized, psychodynamically oriented psychotherapy that uses the transference relationship to help address intense emotional states and difficulties in interpersonal relationships. A core principle of TFP is the belief that internal images of the self in relation to others based on developmental experience exists in the mind of all people. This kind of relates to the working model relationships we were talking about in schema-focused therapy. These mental images of self in relation to other are connected by strong emotions. In BPD, these internal mental images can be extreme, intense, and polarized due to both biological and developmental influences in TFP model. And then transference is the activation of these internal images in interactions with people. So, transference with me becomes like, who am I to you in this moment? In the structured setting of therapy, this activation of the internal images of the self in relation to others can be observed and understood as they are experienced in relation to the therapist. It's the idea essentially that interpersonal difficulties that people may have outside of the therapy show up inside of the therapy in between the patient or client and therapist. This treatment model engages reflection on the emotions being experienced in the moment, along with reflection on the reasons that the images are extreme and polarized. This drawing reflection on internal states helps the person to modulate emotions better and to experience both the self and relations with others in a more complex and clear way. Typically lasts between 12 to 18 months of individual therapy, twice weekly. And then, sorry, I'm noticing the time, but I'll try and speed through this. I think just a couple more slides. Oh, GPM, good psychiatric management, uses a multimodal case management model. BPD is understood as a reflection of interpersonal hypersensitivity. As it was originally studied, GPM was developed using psychodynamic principles, largely sort of developed out of supportive psychotherapy. Treatment uses a generalist model that emphasizes improvements in vocational and social functioning and incorporates education about BPD as well as medication management when appropriate. The therapy uses a here and now approach in which the therapist shows interest in the person's experiences and the interpersonal context and thoughts that precede their feelings and behaviors. Focuses on therapeutic alliance, once weekly sessions. It's relatively easy for clinicians to learn and apply. You can do online training. It's like 8-hour self-paced um, training that is probably of all of the different models, the kind of quickest to become proficient in. It's been adapted for use with adolescents, and there's been research that shows that clinician training in GPM may improve their attitudes about treating people with BPD. What about medication? There's relatively limited convincing research about medications that can be very effective in BPD. There's not really any medications that have a really large effect size in BPD. And ideally, the role for medication in the treatment of BPD is relatively limited, although not zero. And it's also important to keep in mind that being on too many medications, we call polypharmacy, is both harmful and very common. If medications can be started, it should be reviewed every 6 months if it's still needed or can be discontinued. In terms of research around medications, we're starting to see that should really try and avoid benzodiazepines in people with BPD. There's emerging evidence that benzodiazepine use may significantly increase the risk for suicide in BPD because of kind of disinhibition, that benzodiazepines can be a little bit disinhibiting. And impulsivity is one of the diagnostic criteria. Those two things, unfortunately, go together to contribute to worse outcomes. I think the ideal role for medication at this point, as far as we can say from a research perspective, is that medications are ideally an option that helps support the main treatment for BPD, which is psychotherapy. Although it's also possible, and in fact, it's very common for people to have multiple diagnoses at the same time. And if somebody has a secondary diagnosis of, say, a major depressive disorder, that there you can make a compelling case then for medication, but we're talking about medication for BPD specifically. And then I think the last thing I'll talk about quickly is called day hospital or partial hospitalization. And this is really for the most severely ill people. Day hospital may be the only realistic option if they cannot be meaningfully engaged in standard outpatient therapy, or if the standard outpatient therapy model is insufficiently containing. I bring this up because I think it's important people know about this. It's available in other areas, including in Canada, but it's no longer available in BC, and we should really be advocating that it is available. written to the at the time as the Minister of Mental Health and Addictions, but advocating for this, and I would encourage other people to advocate as well. There are different protocols, but the main idea is that people go to intensive treatment that includes a number of different parts to it during the day, but then they go home to their regular residence at nighttime. There's good evidence to back this up. That's this original study in 1999 of partial hospitalization. They found a significant a significant decrease in the number of suicide attempts. And then they did these two incredible follow-up studies where 18 months later, you could still see that this reduction in symptoms was persistent. And then incredibly, 8 years later, they tracked these people down and did the reassessment and found that even 8 years later, these benefits were still significantly enduring, including significantly decreased suicidality, 23% versus 74% in the control group. So you can really just see visually here in the top bar, the purple is the people who got a partial hospitalization, and you can see how much the suicide attempts go down over. This is just 18 months. And then this is the self-harming behavior. You can also see that it goes down for the partial hospitalization group, but not the control group. And those are all my slides. Sorry I ran over time. Thank you very much for listening. And if anybody has any questions, I'm happy to hear them.
Wonderful. Thank you so much. I learned a lot during your presentation. I appreciate your time. We do have one question from two different people. So similar question here is the curiosity around discerning which modalities to use, like which one's a better fit. Is it based
Mhm.
off of presentation, worldview, in terms of like therapist training, client referrals?
Totally. Sorry, I just saw your message.
And no worries about the time. Yeah.
Thank you. Yeah. So it's a good question. I think the most honest answer is we don't fully know yet. I think generally speaking, it kind of depends on what people's goals are, in the sense that of these different options. I can just go back to the table. Of these different options, they have different intensity levels. So it depends what somebody's goals are, as well as kind of what kinds of, so if somebody's super motivated, has big goals, then a more intensive option makes sense. Um, and then it also depends, I think, on what somebody's most struggling with at that specific time, in the sense that we were talking about the 5 of 9. There's who knows how many different ways you can mathematically meet the 5 of 9, and so there are kind of different clusters of symptoms, I think. um, for example, we're often comparing DBT and TFP because that's the kind of work that I do, and also DBT's probably the least inaccessible of the therapies in BC. And I think for people whose difficulties more revolve around impulsivity and recurrent self-harm, then something like DBT that has a more um, hands-on focus around skills training and 24/7 phone coaching, as kind of containing. I think for somebody whose difficulties more revolve around that, then I think something like DBT might make more sense. But then something if their difficulties revolve around the kind of more identity diffusion stuff, having a really unclear sense of who I am and how that relates to relationships, um, then I think something like TFP may be preferable to DBT in that situation. Um, yeah, does that answer those questions?
Yeah, I think that's great. It's helpful to know that that information is still evolving and just also gives some information about where to kind of go based off that individual need. I have a question actually. I'm
Sure,
wondering
yeah.
for transference-focused psychotherapy, you had mentioned about internal images, and I know
Yeah.
for myself, like I have clients that like don't imagine or visualize, and
Mhm,
is it that type of visualization, or could it be like a somatic experience of knowing who that person seems to them?
mhm. It's a great question. I think when we're talking about internal images, I think we're largely talking about like unconscious representations, and that similar kind of like template for the image being kind of a template of like somebody's working model of who I am, and then who other people are, for the other perspective, and then I think how that then manifests, whether you're talking about through somatic experiences or imaginative processes, I think can kind of depend on the person as well as depend on the situation.
Great. Okay. Thank you. I appreciate that. And we
Of
have
course.
one last question. So you had mentioned about like misinformation in social media, and the question is around your thoughts about the use of social media and sharing information about specifically mental health interventions. Like, is
Hmm.
there a risk in that leading to potential harm?
Hmm.
Mhm.
That's a great question. I think that's something we could spend the next 30 minutes talking about. I think it's such a double-edged sword, in the sense that I think, I've seen some like really moving work around destigmatization and awareness and getting high quality information out there. But the like nature of social media also means that, um, misinformation can kind of run unchecked and can be very harmful. I think we talked about misinformation around autism. There's also a lot of misinformation about people who struggle with pathological narcissism, that like that the term like narcissist is used like as like a pejorative like slur almost in social media, which is I think really cruel and unfair, and we know that NPD is treatable as well, and yeah, so I think I think you can make a pretty compelling argument in either direction. I think there's really pros and cons. I think it's probably somewhere in the middle that where like can do important advocacy work, but at the same time like kind of being consuming this content mindfully, and being open to the possibility that what we're seeing on social media may be wrong.
Great. Yeah, that makes a lot of sense. I just actually have one follow-up question, and this relates to what somebody had asked in terms about like securing therapy, like how
Hmm.
the accessibility of these different modalities, maybe speaking
Hmm.
about personality disorder BC.
Hmm. For sure. I think it's I hope in the not too distant future, people can, in terms of the question of like who does better with which, I think a big part of that is also like up to the person. Like, well, what do you want? And then I think that is kind of part of wanting to run through quickly the description of these different models. It's like, which of these seems most appealing to you, as the person, instead of being told like, this is what you need to do. And yeah, I think in terms of accessibility, I think it's important that people are aware that all these different options exist, and then can start talking about it and asking like, well, how come we don't have this here yet, and how do we get it, here? Like call your MLA and ask what they're doing to make this happen. Um, and at the same time, I think it is, to be fair, a harder problem than, like I was saying, like getting a new medication here, in the sense you can just like make more pills of whatever the new medication is and ship it over. It's a much more significant undertaking, like training people in each of these models. And some of these models, are designed to be able to be learned kind of quickly, like GPM. Some of them take a long time to become proficient in. Um, And now with so much stuff going virtually, I think different sort of health professions have different rules around seeing people in different areas. But I know that, yeah, different areas have like different rules around if you can see somebody in another province or something like that. So like if if somebody's looking for therapy and, one of these seven options really appeals to them, like looking, Googling, like, okay, well, where can you find steps, for example, and then getting in contact with, even if it's in Alberta or something like that, getting in contact with them and saying, hey, do you know anybody in BC? What are the rules? Can you see somebody in BC? I think virtual health provides a lot of opportunities for solving this problem of accessibility.
Well, thank you so much. And if people
My
want
pleasure.
to learn more about personality disorder BC, do you want us to like drop a link for the website or?
Oh yeah, sure. Yeah, it's just a personality disorder BC.ca.
Okay.
If you Google us, we should come up. But
Yeah,
yeah, I don't want
and
to be too self-promoting.
it's okay. You're welcome to let people know that that's a service that's offered to people. Yeah,
Thank you very much.
you're welcome. Um, and I appreciate your time, and
Of course.
I hope you have a good rest of your day.
Thank you. Everyone
Thank you.
else as well.